So, good afternoon, and today again I am going to talk about tuberculosis, which is an important topic, and we have partly covered the topic in previous classes. So, again the NMC allotted topic is effect of tuberculosis or effect of diabetes and HIV on tuberculosis. So, this is a two-way relationship, as I already mentioned in my last class that these are basically double troubles. So, HIV can influence tuberculosis, tuberculosis can influence HIV. Diabetes can influence tuberculosis to a significant extent, and again I'll have to go through some of the previous slides. So, how do you define tuberculosis? It's a chronic granulomatous disease. So, remember the pathology. It's a granuloma formation caused by a slow growing acid fast bacillus known as Mycobacterium tuberculosis. It has many other bacteria, and that is known as Mycobacterium class. The most common site of affection is lungs, but there are extrapulmonary sites also which may be involved in tuberculosis. So, this used to be a very important leading cause of infectious disease worldwide before COVID-19 set in. So, COVID-19 was seen from December 2020 till 22 and or 23. So, that became the leading cause of death during this period. Basic mechanism of infection in Mycobacterium tuberculosis is inhalation of infectious organisms, which is through inhalation of aerosols which are generated during coughing, talking or sneezing. So, this leads to infection in the susceptible individual who is in a close vicinity. As already told you, it has a worldwide distribution and 1/4 of the world's population is infected. Active disease, infection, latent tuberculosis, this I have already explained you. So, what is unique to this geographical map? You can see here, these are the dark green zones indicating a high density of cases or high incidence of cases. This was presented in 2019, and the number is about 200 to 299 per 100,000 population, which is quite significant. So, our country, the Southeastern Asia and the sub-Saharan region of the Africa plus South American, the western part is also having a high incidence of tuberculosis. Now, again revising the pathogenesis, it's a human to human transmission. You can see here Mycobacterium tuberculosis is spread through aerosol generation, and it leads to infection in the susceptible individual, which leads to initial infection and initiation of further pathological processes. So, once the bacilli enter into the lungs, it is then tried to rescued by the macrophages. So then these two immunities, one is the innate and the other is the cellular immunity, which come into play. So compromising of neutrophils, lymphocytes, and then the result is that there is some necrosis of the cells plus necrosis and a formation of granulation tissue in the affected area. The adaptive immune phase with containment of infection occurs in 90% of the individuals. So these patients become asymptomatic though they are infected. Then the body's mechanism leads to calcification in the granuloma, which is formed in the various tissues, most commonly in the lungs. It can be tuberculosis in the CNS as well, but the commonest site is lung. So calcification, this will remain dormant for years and years or till the life of the patient. Now, then there are certain factors which can cause the Mycobacterium tuberculosis to proliferate, and then what results is a caseating granuloma. You can see here the granuloma which is surrounded by T cells and B cells. And of course, then T cell immunity comes into play, and this will limit the infection, and this will lead to control of the infection within the body. Now, 90% of these patients who have inhaled the Mycobacterium bacilli would not have much problems, but in 10% there may be dissemination or reactivation and then dissemination. So this is the basic pathogenesis which you must remember. Calcified granuloma on the other hand, and active tuberculosis, which occurs later on due to reactivation in 10% of the individuals. Again, telling you the basic WHO facts. 2023, an estimated 10.8 million people fell ill with TB worldwide, including 6 million men, 3.6 million women and 1.3 million children. So these statistics are very important. A total of 1.25 million people died from tuberculosis in 2023, including 161,000 people with HIV infection. So this is a staggering data, and still we are struggling with it, and the World WHO aims to reduce the incidence to negligible level by 2035. It was also the leading killer of people with HIV and a major cause of death related to antimicrobial resistance. But HIV, because of the revolutionary HAART or highly active antiretroviral therapy, leads to diminution in infection or diminution of opportunistic infection. But on the other hand, there may be a problem due to antimicrobial treatment resistance. TB is present in all countries and all age groups. It is curable and preventable. So as I told you, it's a complex, and the other names are Mycobacterium africanum, Mycobacterium bovis, which is transmitted through unpasteurized milk. Global incidence of TB peaked around 2003 and was declining until 2020, and then COVID came in. So there was an increase in TB incidence after the COVID pandemic also. Acid fast bacillus term is used synonymously with Mycobacterium. The other organisms which are acid fast are Nocardia and Mycobacterium leprae, which are less acid fast. Now, what are the risk factors? Poverty, HIV, drug resistance are major contributors to the resurgence of TB global epidemic. Socio-economic development and access to quality of health services, these are the important factors which influence the presence of infection in the community. 95% of TB cases occur in resource limited countries, which I had shown you in the map. Approximately 1 in 12 new TB cases occur in individuals who are infected with HIV, and 74% of these HIV co-infected persons reside in Africa. So, HIV incidence was very high in sub-Saharan Africa. Large proportion of the global burden of HIV associated TB occurs in sub-Saharan Africa, with 74% of new cases of TB and 79% of deaths due to HIV and TB. The annual incidence in some of the countries of Southern Africa may exceed 1000 per 100,000 population, as compared to 200 to 299 in other areas. Magnitude of risk is highly variable depending on the degree of HIV induced immunosuppression. So, talking of HIV, the degree of immunosuppression is very important. Risk of disease and death from TB is substantially increased among HIV infected individuals due to reactivation from pre-existing TB infection. As I told you, in pathogenesis, it may remain dormant, but whenever there is a superimposed HIV infection, the immune system failure is there, patient becomes immunocompromised, and there is resurgence or reactivation of tuberculosis. Another factor is that if a patient has become HIV positive and develops tuberculosis, the progression would be very rapid. What are the other pulmonary manifestations of HIV infection? So, it is responsible for infectious and non-infectious respiratory conditions. Most complications occur in those not receiving antiretroviral therapy. As already told you that it is a revolutionary treatment, patients are getting cured of HIV infection, and then these complications are not arising. Effective antiretroviral therapy has reduced but not eliminated the excess risk of pulmonary infection, which are the common infection, PCP pneumonia, a very important infection which used to be there but now has declined, and the other bacterial pneumonias. Non-infectious conditions can also be there in HIV infected individuals. These are COPD, lung cancer. So, HIV is a risk factor for lung cancer as well. How do you approach a patient of HIV? The differential diagnosis is influenced by the stage of immunosuppression, patient whether he is taking antiretroviral therapy or not, or prophylaxis for opportunistic infections, OIs has been given or not, and the local epidemiology of conditions such as tuberculosis, whether it is rampant there or not, and the other endemic fungal infections. Lower CD4 cell counts increases the risk of all pulmonary infection, including those that occur at a higher CD4 cell count. However, infections and other conditions can also be distinguished by simple chest X-ray. The clinical presentation of TB in a patient with HIV depends on the degree of immunosuppression. The more the immunosuppression, the more serious is the disease. Those with higher CD4 cell count, more than 400 cells per mm cube, present similarly to those without HIV, like a normal immunocompetent individual. And in immunocompetent individuals, you know that upper lobe cavity disease is a very common sight, low risk of extrapulmonary dissemination, and presence of constitutional symptoms may or may not be there. So, CD4 cell count more than 400, the routine site of infection is the upper lobe. When the immunosuppression advances with CD4 cell count falling down, these patients are more likely to have disseminated disease with prominent constitutional symptoms and unusual pulmonary manifestations, which are mediastinal hilar lymphadenopathy, focal lower lobe or diffuse interstitial infiltrates, and pleural effusions, and sometimes miliary tuberculosis as well. So, this is how it is differentiated from a person of HIV having adequate CD4 cell count than from a person who has a lower CD4 count. Now, what are the causes of cavitary disease in a patient having pulmonary infection? So, cavitation is produced by bacterial pneumonias caused by Pseudomonas, Staph aureus, particularly more common in children, Enterobacteriaceae group of individuals, Mycobacterium tuberculosis, Cryptococcus neoformans, and Rhodococcus equi. This is one important organism, though it is rare, but is known for cavitary disease. Aspergillosis also settles down or proliferates in a cavitary disease, which can be due to pre-existent or a complicated or a sequel of tuberculosis. Nocardia can also produce cavitary disease, avium complex or pneumocystis xerovecii infection can cause cavitation. So, these are the causes of pulmonary cavitation. So, talking about mycobacterial infections in HIV, in cases with advanced immunosuppression, sputum acid fast smears are less likely to be positive than those with cavitary disease. Diagnosis may ultimately be made with alternative methods such as blood cultures positive in 1/4 to 1/2 of the patient. If the patient has HIV infection, it is more likely to yield a positive culture in blood. Patient with miliary tuberculosis or miliary dissemination, these patients may yield positive results on blood cultures. Otherwise, in a solitary case of lung involvement in an immunocompetent individual, blood cultures may not be positive. Then what are the methods to diagnose? Tissue biopsy of the involved structure like a lymph node, bone marrow or liver. Then NAT is one important test which can be subjected to these various specimens of the body, nucleic acid amplification test. Again, the HIV, how does it influence the tuberculosis? Risk of TB doubles within the first year of HIV seroconversion due to rapid depletion of TB specific T helper cells. Thereafter, the risk of TB progressively increases with declining immunity. HIV infected individuals appear to be more likely to acquire tuberculosis if exposed, and they are at increased risk of developing TB disease from reactivation. HIV infection is a risk factor for accelerated progression of TB following exposure. So, it is a double trouble in that way. TB appears to increase the risk of progression to acquired immunodeficiency syndrome from HIV infection, or the mortality also increases because of this. TB infection is associated with significant increase in HIV viremia. Viremia usually declines after initiation of successful TB treatment. So, treatment of both conditions is important in order to tackle these things. Long term risk of TB decreases with initiation of ART. What is NAT? Why it should be done? Why it should be done? When it should be done? What is the impact of HIV on TB or TB on HIV? लास्ट क्लास में थे क्या आप? नहीं, अभी भी एब्सेंट भेजे. दे आर नॉट इंटरेस्टेड. ठीक है, बैठ जाओ. हाँ. So the other risk factors are substance use, tobacco smoking, or use in other form, alcohol if consumed in 40 gram per day or more, because alcohol affects the immune system as well. Malnutrition is an important risk factor of TB. Underweight persons, they have increased risk. As I told you last time also, vitamin D, in an Australian study it was found that those who have low vitamin D level, studied in a population of about 50,000, there is an increased risk of tuberculosis. Silicosis and tuberculosis sometimes go hand in hand, and silicosis is another important risk factor. Malignancy, the risk of TB is increased in patients with hematological malignancies and head and neck cancers. Renal disease, gastric surgeries, celiac disease, COPD and cirrhosis of liver are other important conditions, and close household contact with an individual with smear positive TB is the most important risk factor for TB. Birth in TB endemic areas, socioeconomic status, as I have already enumerated these factors. Now coming to another important comorbidity, which is diabetes. So the risk of developing TB increases with increasing diabetes severity. In a study of 5290 patients, it was demonstrated that poorly controlled diabetes confers almost a 3 times risk of developing pulmonary TB. So there is an important factor. So 3 times chances are that he will be infected with TB. And if the diabetes is well controlled, the disease is not affecting those individuals. So this is very important. Case control study, control was diabetes patient without who were adequately controlled. On the other hand, there were diabetic patients who were not controlled. So controlled diabetes and non-controlled, it was 3 times the risk. Mechanism by which diabetes confers an altered immune response to tuberculosis not fully understood, but may be related in part to altered cytokine expression. Now diabetes also leads to other infections. The most common are surgical site infections, soft tissue infections, skin and soft tissue infections, and surgical site infection. So most of these studies suggest that risk of infection in diabetes is associated with hyperglycemia or lack of diabetes control. Diabetes, and then if the diabetic patient has post-operative hyperglycemia, this was strongly associated with surgical site infection. So diabetes and infection much solidly documented in patients having surgical site infection or undergoing surgery. And uncontrolled glucose level post-operatively is the most important independent risk factor for infection. So, tuberculosis and other infections are also common in diabetes. Now, what are the host factors that cause infection in these patients? Hyperglycemia induced impairment of the immune response. So, glucose levels impair the immune response, vascular insufficiency, sensory peripheral neuropathy, autonomic neuropathy, skin and mucosal colonization with pathogens such as Staph aureus and Candida. So, what does hyperglycemia do to the immune system? So, in recruitment, you know that neutrophils are one important. So, neutrophilic chemotaxis and adherence to vascular endothelium, phagocytosis, intracellular bactericidal activity, opsonization, inflammatory cascades, and cell-mediated immunity are all altered in patients with diabetes and hyperglycemia. So, these are the various mechanisms of infection in diabetes. Chemotaxis is affected, adherence to vascular endothelium, phagocytosis, intracellular bactericidal activity, opsonization, inflammatory cascades. Then release of TNF alpha and interleukin beta from lipopolysaccharide stimulated macrophages is reduced in diabetes mice as compared with control. So, these are experimental animal studies which have been translated into human studies as well. And of course, the level of macrophage inflammatory protein 2 mediator of lung neutrophilic recruitment is significantly decreased in diabetic compared with control mice. So, deficiency of this protein leads to delay in recruitment of neutrophils in the lungs and causing infections like bacterial pneumonia or mycobacterial infection. So, summarizing, around 10% all TB patients are HIV positive. In high HIV burden countries, percentage is much more higher. As I have told you, sometimes 1000 per 100,000 population as compared to 200 to 299. People living with HIV are 18 times more likely to develop active TB than HIV negative people. HIV reduces CD4 T cell count, impairing immune response to mycobacterium tuberculosis. TB infection activates immune cells, leading to increased HIV replication, creating a vicious cycle, thus accelerating progression of both disease. So, this is how both infections influence each other. This is a serious public health challenge because both diseases interact in ways that accelerate the progression of each other. As I have already told you, HIV weakens the immune system, CD4 cell, which are crucial for controlling infection. Most important, opportunistic infection and leading cause of death among people with HIV is tuberculosis. Individuals with latent TB infection have 5 to 10% lifetime risk of developing active TB. With HIV, this risk increases to 10% per year as compared to lifetime risk of 10%. In HIV, this is 10% per year. Globally, 15 to 25% of TB cases are estimated to have diabetes. Remember that burden is higher in low and middle income countries, especially in South Asia, and of course, India is a diabetic capital. The dual burden is growing due to rise in diabetes prevalence, some conditions that negatively influence each other. Diabetes increases the risk of active TB by 2 to 3 times. Poorly controlled diabetes impairs innate and adaptive immunity, allowing latent TB to become active. TB can itself worsen glycemic control in diabetes due to stress and inflammation. Chronic hyperglycememia mechanism is impairment in macrophage function, chemotaxis, cytokine production. These immune defects reduce the body's ability to contain mycobacterium tuberculosis, and there may be infection which may be disseminated. and also TB presence may influence insulin secretion, or it may lead to insulin resistance, causing hyperglycemia and diabetes instability. That is all for today. Okay.